Yeah, we are live. You can go ahead.
Okay. Good morning, everybody. Welcome to our third edition of the Elizarov case discussion on trauma and deformity. Today we have a program with 5 people presenting cases and then a similar kind of case presentation from Dr. Divya Ahuja at Chennur. We are also joined by Dr. Badri Narayan from Liverpool and Dr. P. N. Vasudevan from Palakkad. I think Vasu is not joined as yet, but he will be joining soon enough. So with that, let's launch into the first presentation by one of my first fellows. KK, I think, was one of the first people who worked with us as a fellow. Dr. Krishnakumar Mechoor is now in Thrissur, does a lot of Elizarov and trauma/deformity related work. So KK, all yours.
Thank you very much. A very good morning. I would be presenting a case of deformity after bone transport. So this was a 19-year-old boy. I saw him in 2007 with an infected non-union tibia. He had multiple surgeries before coming to me. So when he came to us, he was on a plaster with a lot of pus discharge from the non-union site, as well as he had multiple sinuses over his entire leg. So we decided to treat him by a ring fixator. So I put him on a ring fixator, but this was before I had any formal training on ring fixators. I put on a 4-ring construct with 2 wires on each ring. There was a 6 centimeter of bone loss after debridement. We did a proximal corticotomy, bone transport, and the bone healed in a year's time. I didn't have the habit of keeping the records at that time, so none of the x-rays or anything else is, or the clinical pictures are available of that particular surgery. So everyone was happy because the bone united. He was walking around. Then in 2009, I had my formal training in Elizarov and reconstructive surgery. So when I came back to my place in 2010, to the end of 2009, I saw this boy again, and he had some difficulty in walking. And the primary problem was when he was walking, his heel was not touching the ground, and he had a deformity on his leg. So these are his clinical pictures, and you can see that he has a bowing, anterior bowing of his entire leg. It's a smooth curve. Plus, his heel was not touching the ground when he was trying to bear weight. So these were his issues, and you can see that he had plantar flexion, but his dorsiflexion was not present. Like his foot was at 90 degrees with respect to the distal segment of the leg. So the problem with walking was basically the deformity on his leg, the anterior bowing of his leg. And these were his x-rays. This was the x-rays which was taken in 2010. This was the transport fragment, and this is the non-union, which was united, but malunited. So his problems were difficulty in walking because his heel was not touching the ground. There was valgus and procurvatum in the distal tibia, procurvatum in the proximal tibia, and also the soft tissues were scar. So we planned for correction again with a ring fixator, and I had the luxury of hexapod at that time. We did a deformity analysis on the proximal tibia. The exact amount of coronal plane deformity was not assessed because he had that deformity sagittal plane component there. So we decided to correct the sagittal plane component first, and then assess again for the coronal plane component, and then do any fine correction at that after that. He had 28 degrees of procurvatum in the proximal tibia, and in the distal tibia, he had a valgus of 8 degrees and a procurvatum of 14 degrees. So that was his deformity planning. These were the decisions which I had to make because he needed a 2-level osteotomy for correction. So whether to do it in single sitting or whether to do it 2 different sittings. And the second was, at what level should I do an osteotomy, or which osteotomy rule should I use? We operated him again in 2011, planned for a 4-ring construct, 2-level correction with hex support, and I decided to use osteotomy rule 2. Why? Because proximally the deformity was very close to the joint and I wanted to do my osteotomy distal to the tibial tuberosity. Distally, again, it was the non-union site. There was some amount of sclerosis there. The bone was not that healthy. So I decided to do an osteotomy at a level which was slightly different from the exact level of the deformity. And 2-stage correction because for me, it was a difficult case and I didn't want to do everything in a single sitting. This was the pre-constructed frame. Even though I was using a hex support, I decided to do a pre-constructed frame so that once the correction is completed, the removal of hex support and fixing rods were easy. So this was for the proximal plane deformity, proximal level deformity, and this is the hinge for the distal level deformity. First stage, we did a distal osteotomy and correction. That was after the distal osteotomy. This is the immediate post-operative planning X-ray for the hex support. Gradually corrected it, and that is the post-correction X-ray. Once the correction was done, this was how it was looking like. Then we went for the proximal level osteotomy. This is the immediate post-operative X-ray after the proximal osteotomy. And this is after the correction. And once the correction, and this is after loosening the fixator, and this is how he was bearing weight on a loose fixator. He was walking comfortably. Radiologically also the healing was good. So we removed the fixator. And this is after fixator removal. Probably 3 months after fixator removal, this was how he was walking around. Now his gait is almost normal. His foot was touching the ground completely. And he came to me a couple of months back. This is 10 years after correction. His foot is fine now. It's touching the ground. He has this much range of movement at the knee. And the only issue was he doesn't have dorsiflexion at the ankle. And these are his follow-up X-rays. Both have consolidated well. So what was wrong during the first surgery? The problem was the stability was compromised because I had only four rings, but on every ring there was only 2 wires. So there was levels of fixation was not taken care of, and there were only 2 wires, and I didn't use any pins and shank screws at that time. My focus was only on union. I somehow wanted to get it united and ignore the rest, especially the alignment part. But second time I corrected all these things. So the learning outcomes here are stability of fixation is very, very important, especially when you are doing some bone transport, because lengthening situations, the soft tissues itself gives some amount of stability, but in transport, your fixator has to be very stable. Alignment again is one of the most important things. Union without proper alignment is as good as a failure. And it's important to avoid creating new deformities when you are correcting an existing deformity. When it is a difficult case, it's always better to do stage surgery because you are dealing only one thing at a particular time. And this procedure definitely has a learning curve. Thank you very much.
Thanks, KK. So that's a good illustration of what the mind doesn't know, the eye cannot see, and all of us have gone through this sort of stage where we were very happy with the result because we weren't able to kind of focus on finding the we were not able to actually delineate what were the problems. I'm sure all of us have gone through this. I know Badri would have. And as we get more experienced, we learn more. Badri, any questions, comments?
No, I think it's it's a great case to show what happens when you're sort of younger on the learning curve. You're looking for quality of bone at the regenerate, and all you're focused on is the quality of the bone. And we then start focusing, as the learning curve improves, only on the coronal plane. And I think the sagittal plane deformity, particularly in younger people, we saw a similar case last month too. It's a killer, you know. They just don't like it. They feel unsteady, etc. And I think the sagittal plane deformity in the transport in the proximal tibia is equally important as the coronal plane. But you corrected it beautifully at the end. It looks fantastic.
So the point that I would like to make is when you want to assess that upper deformity, what you can do is get an X-ray in the plane of the joint. So you will be imaging only that proximal portion, and therefore you can assess whether or not there is a varus valgus in that. Otherwise, everything that you've done is, according to the book, so to speak. So point here is that you should know, and you should continue to audit everything that you do, because nothing kills a good result like a long-term follow-up, as they say. So, and all of us are on the learning. So thanks, KK.
Thank you.
And now I think Ankit is going to talk to share his case of, welcome Vasu. Ankit will share his case of a congenital pseudarthrosis. All yours, Ankit. Ankit is working in Udaipur. He works at that, what is it, Ankit? Which is that place?
So it's called Narayan Seva Sansthan.
Narayan Seva Sanstha. They do a lot of free deformity work. He also does private practice in Udaipur. All yours, Ankit.
Good morning, everyone. Am I audible?
Yes.
Okay. So very good morning, everyone. The topic for my case presentation today is a case of a neglected congenital pseudarthrosis of tibia. So at the time of presentation, the patient was 13 years old. She was a female. As per the history, she has had this bowing of the right leg since birth. And with growth, the deformity and the shortening has progressed. The parents have sought multiple consultations, but no surgical intervention had been done, and no conservative management in form of bracing or shoe raises has been given. At the time of presentation, she was walking with a short limb gait with lurching. There was a visible cosmetic deformity of the leg and significant shortening. She was not using any kind of shoe raises. On lying down position, one can appreciate the S-shaped multiplanar deformities. The K P spots are visible on the skin. And these were her first X-rays showing congenital pseudarthrosis tibia with tapering of the canal, sclerotic ends at the non-union of fibula as well. So when I went ahead with planning and thinking about this case, my first thought process was whether should I intervene at this stage or not, because she is a elder patient as compared to the previous patients which I had operated, which were younger. And if one has to go in with an intervention, is amputation a good option to offer to the patient, given the long multi-stage reconstruction, which is the second option. After discussion with the parents, we went ahead with a reconstructive process. So the next question was, will this process of resection and docking, bone grafting work in this patient as well? or should I consult somebody who will be able to do a good pre-vascularized fibula? Or as the patient was younger, should I go in for a resection of the sclerotic bone and a bone transport? So apart from the non-union, the second problem in this case was this large anterior bowing of the proximal fragment. I went ahead with the standard technique which I had used in a couple of cases previously. Opened through anterolateral incision, I was able to excise the whole sheath of hematoma around the tibia and the fibula, removed away the sclerotic bone, docked the bone into one another using the method of telescoping. And for this proximal deformity, I used a second osteotomy to correct this deformity. So this was the site of non-union, which was freshened and telescoped. Retrograde K wire was put in. And at this point where this K wire was not able to progress more proximally, did another osteotomy, resected some bone, and was corrected this anterior curvature of the proximal tibia. Similarly, the fibula was also resected and fixed. I had intended to go ahead with the bone grafting at this stage also, but this procedure took a lot of time. So did not do bone grafting in the primary stage because I had to do a significant shortening. There was significant tension in the suture line, which ultimately had some marginal necrosis. So bone grafting was delayed for 3 weeks, during which time the patient was put in a cast and regular dressing was done. At 3 weeks, when the suture line was healthy, I went ahead with another incision over the anteromedial side for bone grafting at both the proximal and distal side, and put in a Ilizarov frame. This frame was more of a neutralization frame, not planning for any distraction or compression. At this stage, I did not put a heel ring, retrospectively thinking I should have put one calcaneum ring also to increase the stability. This was the immediate post-op X-ray. Put in bone graft around the non-union site and simple 3-ring construct as a neutralization frame. As you can see, there was a interrotation deformity here, but I did not correct this deformity at the time of putting on this Ilizarov frame because I did not want to disturb the internal configuration of telescoping which I had done during the first surgery. And this was 7 months after putting on the Ilizarov. The both sides appear to have united. The patient was able to walk with the rods removed. So removed the Ilizarov after 7 months. This was a clinical picture. The patient, the deformity appeared to have healed. There was definitely internotation deformity and significant shortening, but there was no pain or mobility. After the removal, patient was put on a walking cast for 6 weeks and reassessed after 6 weeks. So now the problem remaining are a significant internal rotation deformity and shortening on the operated right lower limb. This was after 6 weeks of Ilizarov removal. So you can one can see there is union at both sides. The union is tenuous, not significantly healthy, but there was definitely union. So went ahead with the second stage of doing a lengthening and correction of the internotation deformity. So Ilizarov frame was put. This time the calcaneum was also fixed, and proximally an osteotomy was done for lengthening, and also the internotation deformity was corrected acutely. So during the pre-construction of the frame, I put the proximal ring in mismatch in external rotation. After the osteotomy, the nuts were aligned to correct the internal rotation deformity. Started with distraction 2 weeks after the osteotomy, and the rate of distraction was capped at 0.75 mm per day, and which was gradually tapered over time when there was a complaint of stretching pain. So these are pictures at 2 months of distraction and 4 months of distraction. So after 15 months of osteotomy and distraction, there was the regenerate, which was well appreciated in both tibia and fibula in all the views. Patient was able to walk full weight bearing without support on the frame. And at 1.5 years, there was further consolidation. The patient was completely pain-free. And at 1.5 years, the Ilizarov frame was removed. So there is good regenerate in the proximal tibia and fibula. The distal non-union is also gradually continue to consolidifying. And in oblique views also, there is consolidation and union. This is at after the fixator, second fixator removal. In final assessment, the lengthening that was done was 7 centimeter. The patient is still 7 centimeter short. After the frame removal, patient was put on a walking cast for a couple of weeks, and thereafter she has been walking on a splint and a shoelace. This was the gait of the patient before the surgery, walking on toes with a short limb and a cosmetic deformity. This is the latest walking pattern of the patient. This is 3 months now after the reserve removal, and she has started to walk without the walker using the splints. She is a bit tentative at right now with her walking, but hope this gait pattern will further improve with time. Next, my next plan is to regularly see the patient at 6 months and maybe do another lengthening after 2 years or so. The points which I have learned from this case was the union with the standard soft tissue excision, bone alignment and compression works well with also the neglected cases. One can do bone lengthening in cases of CPT in a predictable manner, but we have to keep the rate slower and longer fixator time is expected. And as is the dictum, the union is a priority in deformity correction. Union is the priority over deformity correction in cases of congenital pseudarthrosis of tibia. That's all from my side. Thank you.
Thank you, Ankit. So that was a good case, and this takes me back to the beginning of Elizarov in India, especially, where any CPT, the treatment was supposed to be Elizarov, where you excise the so-called bad bone. There is no such thing as bad bone, we know now. There is only bad soft tissue, and try and do a bone transport to fill in that gap. So the first question to you, Ankit, was if you had to do this case again, what are the things that you would do differently?
First of all, I'll be able to do, I think, I had to do the first procedure in 3 different stages. So maybe I'll be able to do in the same case. I did not use preoperative zoledronic acid in this case, which I have now started using. Maybe I'll start with the infusion and do the surgery 6 weeks or so later. Other than that, I operated another case of a neglected patient, and this time around I was able to put a smaller a plate inside with a nail, which as per the cases I had seen on the internet will be able to give more of internal stability. I don't think I could have put a plate in this child because the bone was very thick, very thin, but maybe I could have tried a internal fixation in this patient, along with Elizarov, definitely.
Yeah. So I'm not so sure that putting in a plate is a good idea. Having an intramedullary splint, as in terms of a TENS or something, yes. But putting in a plate then takes away that entire advantage of the Elizarov, where you can apply compression further as required, number one. Number two is, oftentimes these bones are not good enough. And this is one of the prime examples, congenital pseudarthrosis, is because what I always say is you are not an Elizarov surgeon. You are a reconstructive surgeon. And what that means is you need to know the natural history of every condition that you are treating. It's not just about putting on a fixator and then doing a bone transport. So in congenital pseudarthrosis especially, we know that the natural history of this condition is not, terribly good. There are rates of refracture if you don't do the things such as zoledronic acid, the 4-in-1 kind of fusion. And so you made a very good point there that getting a union in these is very, very important. And getting the union really is from excising that soft tissue, getting internal stability, getting proper alignment. And the elixir of, at least in the primary stage, only serves, in my mind at least, to give rotational stability. The fixators that I use, especially in smaller children, are pretty simple. One ring on the top, one ring on the lower end, especially when they have very small distal ends, and then maybe 3 wires or 4 wires on each ring, which essentially provides rotational stability. The axial stability is provided by the intramedullary tens. So if you have a bigger child like this 13-year-old, then you could have maybe more rings to provide that. The other point I want to bring to your notice is the incision. In these cases, especially when you're considering acute shortening, it's good to have a lazy S incision, because when you shorten it, then that doesn't, become like an accordion, doesn't get bunched up. So you can do a good amount of shortening without problems in the skin. Also is the issue of deformities. Now, if you see this child walking, the most current video that you showed, now I think that there is going to be a separate bunch of patient follow-ups, what can be classified as lockdown follow-ups. Because now getting a post-operative video from any patient, wherever they are in the country, is not a problem at all. You just send them a WhatsApp, do a video, and everybody has got the latest follow-up of all these patients. So there, you notice that in your last X-ray, there is still a proximal recurvatum. And you mustn't forget the remaining deformities in congenital pseudarthrosis, especially when the child comes after a long time. And those deformities are a recurvatum, as in your case, a valgus in the proximal tibia, a valgus in the distal femur, and a valgus in the ankle. These are deformities which nature creates to try and balance that severe procurvatum and varus. So those are things which you can give a thought to correction by growth modulation, so that those deformities also normalize. In your case, there is a varus, there is no valgus apparent in the knee, but that is something which in other cases you will find happening. Vasu, your thoughts, please. You're muted, Vasu.
Yeah. What was the incision you put initially?
It was a longitudinal incision.
Longitudinal where? It was on the lateral side?
Anterolateral, sir.
Anterolateral.
Yes, sir.
Okay. How easy was the procedure?
It was not very easy, but through anterolateral, I have done a couple of cases after this one. So approaching both tibia and fibula non-union is easier from the anterolateral side.
Yes. So it's, as Mangal said, it's essentially a strangulating bone disease. The soft tissue is strangulating the tibia, so it narrows it down and kills the bone in between. And that is why you have to do the circumferential excision of the haematomatous thick periosteum.
Yes.
So as Mangal said, I do on a medial approach, and that's a modified Z-plasty. Modified Z-plasty, I can extend it any length. And through the medial, you have to take care of the vessels, and through the interosseous membrane, I can go to the fibula. Okay. But I don't generally excise, because fibula, even if it gets strangulated, I don't mind much. So sometimes if the fibula is intact, my easiest job, I will be transferring the fibula intact with the periosteum into the defect. So it becomes like a two bones together. Okay. And especially in your case, a 13-year-old girl, I would like to put a intramedullary titanium rod from the medial malleolus just crossing the non-union side. So that will remain there for a long time. And upper end, I'll do a deformity, a corticotomy, and that bowing deformity will be carried along with the lengthening on stage 1 itself.
Okay, sir.
So if you had done a medial approach, I think your procedure would have been much more easier. Anterolateral, you have lot of soft tissue there. So that will, because there you have to be extra careful because your dorsal pedis vessel will be there.
Yes,
Yeah, you can do this through there. You know, it becomes essentially you are exposing right from the medial side to the lateral side, whatever approach that you take. Even if you are medial, you lift the vessels, intra-osseous membrane, and from an anterior or medial approach, you also lay down soft tissue, bone graft between the tibia and the fibula.
Yeah.
Because that is one of the kind of hallmarks of that. Of that 4-in-1 thing which Cho talks about.
And
Right.
you are lucky that you had a case of after 13 years. So generally CPDs behave better after 10 years.
okay, sir.
There is a study which shows that the earlier the presentation and the earlier the surgery, the lesser is the rate of success. So which is the reason why if it is not fractured, you try and pull them on in a brace till they fracture. And now there are a couple of papers, I think you have also seen that, which talk about trying to correct deformities by growth modulation when they are not fractured. That is, in severe anterolateral bowing, you don't try to excise that area and correct it. You can try and correct it with growth modulation. As and when, if and when that area fractures, you can then deal with that. Great. So here, bottom line, I think, is you need to know the condition that you're treating. You're not just an Ilizarov surgeon, you are a reconstructive surgeon, and the Ilizarov is just one of the tools that we use for getting the result. And certainly excision and bone transport in the primary setting is a recipe for disaster. It is difficult enough getting union, so that is what it has. You have to sort of focus on. So nice case. Thank you, Ankit.
Nice case.
Thank you, sir.
Nice. Next, I think Jeejesh. Is Jeejesh around?
Yes, sir.
Yeah. Jeejesh, you can start your case.
Badri has to add anything?
Badri said
I don't do
in
kids.
the beginning he doesn't do kids. That's why I didn't ask him. I haven't forgotten.
Yeah.
So good morning, sir. I'm going to discuss a infected non-union tibia with a diaphyseal deformity. It's a very simple case. So this is the case history. A 43-year-old man presented with the deformity of a leg with Ilizarov on his leg. He came to OPD for amputation of his leg because of 7-year duration of treatment with multiple surgeries, followed by a simple fracture shaft of tibia, which leads to infection, malunion and non-union, which again leads to severe depression, financial debt, and family issues. So this is these clinical pictures. So what are the problems you notice in this? So if you carefully analyze, you can see there are a lot of problems. So if you look at the rods, so this is protruding out and it's not crossed through the Ilizarov ring, and you can see the central bolt positions at each ring is at different level. Ring size is not proper. 2 fingerprint space is not around all there on the limb, and number of rods is not adequate. Application of frame and rods are not proper, and position of the ring hinge joint is at different level, and altogether alignment of the frame to the bone is a problem. So which leads to instability, which again will go to non-union and the infection. So if you look at the X-rays, so you can see that the bone alignment is not proper in the proximally malunion. You can see that, and non-union, there is a distal non-union with a deformity distally. And if you look at the bone quality, the bone ends are hypertrophic and there's no osteoporosis, and so the biology is good here. And because the frame is not properly updated, and the mechanism is bad because of no adequate wear tension, no spanning of the fragment, and the alignment. So the present problems are hypertrophic non-union at the middle and procurement deformity at proximal part of the tibia of 7-year duration, and failed implant on his leg and pin tract infection and discharging signs at non-union site, shortening of about 6 centimeter, and severe mental depression. So how to manage this case? Before going to discuss the treatment part, I would like to show how is this happened. So this is the past history. He sustained a simple closed fracture, and following fall, he was treated with conservative plaster cast from a local hospital, resulting in hypertrophic non later with a deformity. Then he was undergone multiple surgeries from the same surgeon. And deformity correction with the plating and grafting was done after removal of a wedge of bone. And this is his X-ray. After the first surgery, infection started. And what was done next? The second surgery was done, wound debridement twice, and the plate failure occurred and resulted in infected non with the plate failure and deformity of shortening. What was done next? The third surgery was done, plate removal and cast application was done. And how to manage at this stage? So the answer is food debridement with or without antibiotics, or stimulant, followed by fixation with LRS, Elizaro or nail. So here, what was done? Elizaro application was done. So you can see these X-rays. This is the first X-ray is before compression, and second and third X-ray is after compression. So you see everything is okay in this X-rays. If you look at carefully, you can see that proximal ring is the bias is not adequately tensed and bias not adequate in both rings, first and second, and no, there's no spanning of the fragment occurred. So which after compression resulted in the both AP and lateral plane deformities. With the, you can see that the rings is not perpendicular to the axis of the tibia. So what happened next? After the first surgery, Elizaro removal was done, and this is his X-ray, where you can see that's a hypertrophic non with a deformity. So there's a malunion also in the proximally. So how to treat at this stage? It's, as you can see, treat as a aseptic hypertrophic non is just gradual recession with the Elizaro ring. A proper position of the hinge is enough to do this case, and you can proximally you can do acutely also correct. So what was done in that case? So wedge recession, Elizaro application was done, and cortico was done in the proximally. So what are the problems again noticed in this case? This again the same problems occurred in this as like previously. So at this stage, the patient presented to with me to like this. So how do you manage now? So the treatment options available are amputation process. The patient wants to amputate, implant removal and wound debridement nailing, or plus or minus bone grafting, plating, Elizaro, and LRS. So which is the best options here? So, and which is the best definitive surgery, because he wants to do in a single shot everything. So he's not willing for Elizaro again. So what is the best option? So I decided to do Elizaro with implant removal and wound debridement. So a treatment principle I followed is convince the patient, psychiatric consultation needed, implant removal and plaster cast immersion. I gave a treatment-free interval for him. Eradicate the infection with the proper antibiotics, get union by applying the stable fixation, plan the definitive procedure. So this is the treatment interval. I removed the Elizaro and put a cast, and this is the clinical picture just before the surgery. So my plan was to do two-stage surgery. First stage, apply Elizaro ring and correct the major deformity by acute correction or by gradual correction. Then second stage, do the corticotomy proximally and lengthening. So I don't want to do the residual deformities and shortening and all. I just want him to walk as early as possible. So I opted the option 2. So this is after Elizaro application. So I improved the mechanics by doing the proper alignment. The rings are rods are parallel to the anterior border of the tibia, and rings is perpendicular long axis of shaft of tibia, and proper wire tensioning, adequate spanning of the fragment, and make the bone ends transfers and wound debridement so that the biology also is improved. So the tip is improve the biology means so thorough debridement, freshening of the bone ends, and improve the mechanics by make the bone ends transfers or instead you can, and stable frame pouring construction. In this case, apply the frame parallel to the anterior border and perpendicular long axis of tibia, spanning the fragment by shank spins or drop wires, adequate wire tensioning, optimum number of rods or wires or shank spin to use, and optimum number of rods also to use. This is after application of the Elizaro clinical picture, where early mobilization was done and early walking. So with a foot raise. So he's walking comfortably, and this is the X-ray after the union. The alignment is okay. The total duration was only 4.5 months, and eradicated infection after, and united well. And LLD and proximal deformity remained as he's not willing to correct at And he was very happy and both mentally and physically, and advised him to do the residual deformity at later stage once he is mentally and economically stable. And regarding the discussion, in aseptic non-union, hypertrophic non-union, you have to just distraction at the non-union is enough. No need of any corticotomy, lengthening, pressing of the bones, and bone graft is not required. So what could have been done initially in the above case? So this I want to show you another case so that it will be very easy to understand. It's a similar case. There's a percurvatum deformity with a stiff hypertrophic non-union with a broken plate inside. So this case, how do you manage the? So this is managed just by applying the proper frame over the deformity with according pre-constructed frame has to make, and the hinge has to be properly positioned, and just distraction is enough to do the union. So this could have been done in the above case very easily. So the take-home message is follow the basic principle of fracture fixation, follow the basic principle of Lizard fixation and the principle of deformity correction, and study about the case properly before jumping to the treatment. Think about patient mental and social status of discuss the treatment plan with the patient. Only a good trauma surgeon can be done, become a good Lizard surgeon. Thank you.
Thank you, Jeejesh. So one more take-home message is force the patient to do what he doesn't want to do. Right? But this happens frequently that patients have had a poor application of the Elizarov, and then they blame. Don't take it off. Just one sec. Don't take off your pictures. So and then they blame the Elizarov and come and tell you that all of us have cases like that. The patient will come and say, "Doctor, you take my leg off. I don't want this ring on my leg again." Basically, because they have gone through pain and suffering with that Elizarov fixator. That's because it has not been put stably. Now, just go back to the earlier treatment that you were showing before he came to you. Yeah, that one.
Sure, sir.
No, one more. No, the Elizarov on the, okay, this one. So now here you see on the lateral X-ray especially, if a surgeon was to tell me that, but I put on a 4-ring construct, a 4-ring construct which is so close together without spanning the fragment, which is not perpendicular to the bone, is not really doing the job. You need stability, and this is where I differ with people who talk about the magic of Elizarov. There is no magic in Elizarov. The magic of Elizarov is stability, just like the magic of plating is stability, just like the magic of nailing is stability. And until we learn how to apply that stability or get that stability with this adult mechano set, we continue to have trouble, So this is also a 4-ring frame, and what you have showed later on in your case is also a 4-ring frame. And there is a huge difference between both of these. So this is also a 4-ring frame, but 4-ring frame appropriately positioned, appropriately aligned. Badri, your opinion, your questions.
I used to see this kind of cases before, but luckily in the system I work in now, after the first non-union, they are referred on. But as you said, Mangal, and I'm sure Vasu will agree, this concept that people have that just put on an X-fix or just put on an Elizarov, it'll be sorted out, is something that I think only education will help, because you can see the immediate difference that the near and far construct and the alignment has caused to the biology of the fracture. That, as Mangal said, that was a pre-assembled 4-ring frame that had been slid on the leg, wires passed, and people, I think, hope for the best. Whereas your frame has got even though it's a simple case in terms of the complexity of what you showed last week with that wrist, it just shows the value of sticking to principles and getting the rings perpendicular to the tibia in both planes, and immediate impact on the patient.
And the term I use for this is, an elegant, humane frame, because this kind of frame, the patient is not going to complain of pain and all those issues.
Yeah, Mangal.
Vasu?
Yeah, you told it's a magic. No, even magic, not everybody can do magic. You must learn how to do the magic.
Exactly. But once you learn, you can do it.
Yeah, that's it. So even with Dilizora is a magic, though
Yeah.
who says it's a magic, they must teach people how to do the magic.
Yes.
That most magicians will not do it.
The problem is most magicians keep their hand behind the handkerchief and then just show the rabbit.
Yeah, that is the mental status behind all the magical teachers.
Okay.
So that is magical teachers. That itself is the magic. So that way it's not going to work at all. So we have to expose it. It's not magic. It's a real thing, reality, which is possible in anybody's hand. And
Yes.
even for Jeejesh,
Yes, sir.
I think I won't do like this. I will do the upper corticotomy also.
So here, why I didn't do that is one is the time. I have to make him mentally stable. And another thing is a less number of implants I have to use. As far as maximum less number of implants I have to use.
Just imagine you are doing a corticotomy. How much extra implant you have to use?
No, that
Couple of pins.
yeah,
Yeah.
that you can do is, but
And how much time it will take?
but patient himself, I discussed the treatment, sir. In this case, the treatment I discussed the patient.
So the
And,
same time you can take it out. And once you align it well,
Yeah,
the
correct.
response on the fracture non-wounding side is much better.
Yes, sir. That also is an option, but the patient in this
Don't
case,
take much time, maybe 15 minutes for you.
correct.
Yeah, I think so. Both sides are kind of correct. On Vasu's behalf, Jeejesh, I would say that you could have spent 30 minutes longer in twisting the patient's arm to allow him to to accept the lengthening also. And then again, okay, you want to say that I only want it. Patient says I only want it healed and I don't want any more risk. Okay, but I think today, if you see some things happen depending also based on your experience, in the sense as you get more confident that yes, I will be able to carry out this case without too much trouble, then you can start adding on those other components also. So I don't know when was this case done, early on or more recently?
Earlier one, 2012.
Yeah, so that's what. So once you start, now probably if the same guy comes to you and you have 5 patients walking in the OPD with a good fixator, it's easier for you to convince the patient that, see, when we do the Elizarov, patients do well. Do you see this guy having trouble? No. So don't worry, we will, take you through kind of. Great. Thank you.
Nice case. Congratulations, Jeejesh. Nice.
Thank you, sir.
So the next is Vikram, who's just finished his fellowship last month. So this was a case that was done when he was around. He was involved in that. So go ahead, Vikram.
Thank you, sir, for the opportunity to present a case done in CLLR. I'm presenting the case of an infected gap non-union tibia in which stage treatment was done. This boy came to us with an RTA in April 2018, in which he suffered a closed right femur shaft fracture in which interlocking nailing was done. He also suffered from an open type 3B right tibia shaft segmental fracture, which was debrided and sutured initially, followed by a contralateral rotatory gastrosoleus flap with an X-fix, and interlocking nailing was done 1 month later. When he came to us in December 2018, he had discharging sinus from the distal third right leg with the local temperature being raised. Range of motion of the knee was full, and the ankle there was stiffness at the ankle with 5 to 20 degrees of plantar flexion. These are the clinical pictures of the limb from the front, side, and the back. This shows the range of motion of the knee to be full, and the ankle is stiff in slight equinus. The patient was walking with a painless limb on the right side. On the pre-op X-rays, we can see that the coronal alignment seems to be well maintained. On the lateral view in the tibia, we can see that the the middle part of the segmental fracture is posteriorly translated slightly, and there are signs of infection throughout the intermedullary canal. So the plan, when we took him for this surgery, the plan was to for implant removal, lifting of the flap, debridement sequestrectomy, and then the gap which was created to be filled up with antibiotic-coated stimulant, and then followed by a delayed osteotomy and a bone transport later on. So we lifted the flap, the necrotic bone was exposed, debridement and sequestrectomy was done. The flattening of the fracture ends was done, and the curettage of the intramedullary canal was done, and the frame was applied. And the gap which was there was filled up with the antibiotic-coated stimulant. In the post-op X-ray, we could see, we noticed that there was a recurvatum deformity at the distal non-union gap site, and so we decided to correct the deformity as well as dock it immediately, as well as dock it acutely, followed by a lengthening later on instead of the bone transport which we had originally thought about. So this is, we corrected the angulation using the ortho SUV frame and then docked it acutely. You may notice that the distal fragment is slightly anteriorly translated. That was to get the sagittal axis of the lower limb correct, because the proximal fracture site is slightly posteriorly translated. After removal of the ortho SUV frame, we can see that the fracture is docked. On the lateral view, the sagittal axis seems to be well aligned, and there is healing seen in the proximal fracture site. After 2 months, proximal corticotomy was done and lengthening was started. After 60 days and 2 months of distraction was done. Since the patient was in Goa, not in Mumbai, so this is the way we clinically assessed the lengthening which was happening, by instructing the patient to send us pictures on a regular basis. At the end of 2 months, the length, we got him to Mumbai, got a full length X-ray done. The length was pretty much maintained, equal now. So we stopped the distraction. Within 6 months, the regenerate had solidified completely, and the non-union site had also healed up nicely. So we decided to, these are the clinical images of the patient with the frame, and he's walking well without any unaided, and there were no problems. The ankle seems to be, there seems to be slight dorsiflexion of the ankle as well. So we removed the fixator and gave him a below knee cast. And this is after 1.5 months in the cast. So we, at that time, we removed the cast, and on stress test, he was walking well. There was no pain, and X-ray showed good healing. So we decided to let him walk without without any brace or any cast. We just advised him to use a stick for the next 1 month. This is him walking without the cast. On retrospect, we had seen that there was slight equinus at the ankle. So the patient came back 2 weeks later after having severe pain while walking. On X-ray, we saw that the non-union site had refractured, So since it was a low energy fracture and the fracture was undisplaced, so we decided to give him a cast, above knee cast. Then the lockdown happened and the patient was able to just send images from his native place, that's Goa. And there we see that the fracture is well uniting after 3.5 months, and the patient was walking with the cast at home using a stick. This is 6 months after the refracture and casting. We see that the fracture has nearly united, and so we gave him a PTB cast to be worn. And this is the final follow-up after 11 months of refracture. The learning points which we got in this case was, we have to balance between the removal and retention of the bone in an infected case of intramedullary chronic osteomyelitis, because if we take out too much of the bone, then that increases the treatment time, and if we remove less, then that would not let the infection settle down. Proper alignment of the knee to the ankle is necessary. This we ensured by the anterior translation of the distal fragment, so that the sagittal alignment was maintained. Good cross section of union at the non-union site is essential, because if the union is thin, the cross section is a little smaller than the thickness of the bone, then that may act as a stress riser, and any unnatural force on the bone will give rise to a fracture at that region. Regular follow-up is essential, especially in these Ilizarov and lengthening cases, so that we are able to identify problems early and rectify them before any major issues occur. It's a good idea to give protected weight bearing in the form of cast or a brace, especially if you are unsure of the union. Ankle and knee stiffness may cause fracture at the stress riser. I feel that this was one of the reasons for the refracture which happened in the tibia, because the ankle was stiff and there was slight equinus. But as we had noticed that with the fixator on, there was ankle was going into slight dorsiflexion. But I think after the removal of the fixator, when we had applied the cast, there was slight equinus, I think accidentally given in the cast, and that led to this posterior forces being applied on the tibia, and that may have caused the fracture at the stress riser point. That was the union site. If on retrospect, I think giving a rocker bottom footwear or a brace would have been a good idea to avoid a refracture. And since this fracture was a undisplaced and a very, very low energy type of fracture, cast, we were very lucky to get away with a cast, and the fracture healed without giving us any trouble. Thank you.
Thank you, Vikram. So I'll leave this to Vasu and first, and then Badri to comment and question.
As Vikram said, the equinus is a major force for refracture. So what I do now, generally, if they have limited dorsiflexion, I give them a high heel on both sides. Bilaterally, same time. So rocker bottom, many people may not accept it because the shape is little different. So give them a high heel and see that all of them have a dorsiflexion. So equinus create, because as they walk, the heel is not touching the floor. So his body weight will try to break somewhere in the bone, so as to get the dorsiflexion.
Yes, sir.
So I generally give a high heel if they have it. So let them walk on that for 3 to 6 months. Later on, we can do something about it. Generally, it comes back.
Okay,
Slowly, we can reduce the heel size on both sides, slowly 1 centimeter by one level each time, and bring it down. And otherwise, it's a very nice case, and the planning, everything has been good.
Yes, thanks.
Can I ask, how did you know that it was actually united distally? Was it based on a CT, or do you get just X-rays to check, or do you detension the fixator and see if he's got pain before you assume that the distal side is healed?
Generally, we assess it on X-rays. If we have any doubts, then we go for a CT. And even if we have no doubts and the X-ray is showing good union, we generally loosen the fixator and then take it off in a stepwise fashion, sir. So that if any issues are happening, then we can just reconnect the fixator again, and then we'll be in the safe zone.
And before you do that, once the ends dock, do you freshen the docking site formally in all patients, or do you say, oh, I've got a lot of contact? Do you do any mechanical maneuvers to the docking site after you got contact? I can tell you why, because I've been bitten by this quite regularly during the initial part of my career. And it went to a point that routinely now, and I know this is not accepted practice by every Elizarov surgeon, but and at least in our unit, all of us routinely open up the docking site and freshen it, because all these mechanical maneuvers that we tried in the initial few years of our practice never seem to work. I don't know what the views of Mangal and Vasu are regarding to this, because this is the bane of our practice, isn't it? You spend 12 months treating the patient, and then he refractures at the docking site.
If I had an opportunity to open any non-union, I'll see that there's a good intrinsic stability.
Yeah.
Reshape the bone so that it directly is sharing the load. So some sort of reforming, like one of the cortex I making the thin this thing and interpose into it and keep it in the intermedullary area, reshape it of any directions. A minimal translation that way, this way is not a big issue. And once it is docked inside, you can do rotation also there.
Yeah.
So I always see that it is, and you have double contact there. So more cortex at that level. That is one thing. And the locally available some curettage bone, good bones I usually apply as a bone graft. Some of the graft may come off, but still it is useful.
So do you routinely then open the docking site, Vasu? Is that what you're saying?
No. The indication for opening is if I wanted to remove an implant.
Oh, I see. Okay. Yeah.
If I wanted to remove a sequester. So if I think the docking site is not good. So these are
but Vasu, what he's asking is, suppose you are doing a bone transport.
I don't do it.
Then routinely you don't do the bone graft.
Yeah, and I generally what I try to do acute docking.
Exactly.
Okay.
So I agree with that, because wherever feasible, I will try and do an acute shortening and then a lengthening for exactly this reason, that when it has been transported for a while, then ultimately you have the skin invagination and stuff.
Yeah.
So only when it is very long segments that we won't do that.
Even
now,
in that case, we can shorten it to a certain extent.
Yeah, you can.
Yeah.
So in this particular case, so we had a good docking. These are good vascular ends. So we didn't bone graft it at that time. And I think we were right in the sense that it healed. But the issue there was that the cross-section of healing was not good enough. So wherever that is not up to the mark, then I would like to sort of protect it with some kind of a brace or something like that. In retrospect, putting in bone graft and broadening that area would have been a good idea, but nature did that for us by creating a low energy fracture, creating a hematoma, and broadening that cross union itself. But we will always go with X-rays, AP lateral and both obliques. In the slightest element of doubt, we will do CT, and even in those cases where we think it's healed by all these methods, we will do that stress test. That is, loosen the area of take out the rods between the proximal and the distal fragment, let them walk and see that their gait is normal. And that video which he showed of the patient walking with the fixator, that's what I call a ready for removal walk. Until that patient is walking like that, I am not, and I say this often to patients, that if my results are slightly better than the next guy, the reason is I am better able to resist the pressure of patients. Not necessarily that I have a better surgical hand, because patients start pushing you. When are you going to take it off? When are you going to take it off? And I say, as soon as your bone is healed, so that onus is kind of on you, you know. And if that bone is not healed, with time and with sort of experience, I can now start pushing patients for a bone grafting if, you know, before time. Say I've done a bone transport and the lower portion doesn't look that good. So 2-3 months before the regenerate has fully solidified and I find the union below is not that good, I may start telling them that, you know, I think we should do a bone grafting so that your fixator will come off quicker, kind of thing. So it's more of preventing problems. But I think the lesson learned here is, despite all of that knowledge, despite all of that predictive, you know, ability to predict, you still end up with you can still end up with trouble. So
even see this, his gait is a stiff equinus angle gait. He's just little jumping off.
Yeah.
So that can produce the problem. Then, and next thing is, I usually call that clinical testing as trial walk. So what I do, I take the measurement of all the rods and enter on a paper, loosen it completely and ask them to walk and watch it. So I'll ask the patient, how do you feel now? Generally, if it is well healed, patient will say, no, I feel very comfortable. Better than earlier. My weight has come down. My limb is now very light. And then what I do, I take the measurement, reapply the rods, take the measurement again. If the measurement is more than 3 to 5 millimeters extra, then I think there is some problem. So the shape has changed. If any doubt there, I will ask them to do a 1/4 millimeter morning evening distraction.
Badri, there is, yeah, sorry, go on.
Yeah, I do a 1/4 millimeter morning, 1/4 millimeter evening distraction for about 10 days. If it is going to break, it will break in that. Or they will develop pain. So as soon as they develop pain, I'll ask them, where is the pain? The pain is on the pin sides, so that means the fracture is very well healed. The pain is at the fracture side, so that means the fracture is going to break.
And then you will graft it.
Yeah.
Okay. Badri, there is a question on the YouTube chat. What measures would you take intraoperatively? What are the methods? This is from Dr. Satish Nesari, who's from Belgaum. What are the methods intraoperatively to prevent recurvatum in Dr. Vikram case? So when you put on the fixator on table, while you're putting it on, what are the things you do to ensure that there is no recurvatum or to minimize the incidence of recurvatum?
I think, so this was the one where you had a long gap and it just slid into recurvatum.
Just the case which he showed just now.
Yeah. I think it's a challenging one because the soft tissue contour will be so big, because I think this guy had a local flap there as well. Intraoperatively, the only things I can think of is making sure that your rings are perfectly orthogonal, perpendicular to the tibia in both planes, and clicking the rods on. And if the gap, we just use a formula if the gap is more than the diameter of the ring, we only use telescopic rods. We don't use the simple threaded rods, because I think the simple 6 millimeter threaded rod has a tendency to bend if you use it for more than about 150, 200 mils.
Right. And the other thing now is, to a certain extent, what we do is otherwise ensure on the lateral that the two fragments are well aligned to each other before we fix the distal most. With 6 axis, I think at least I have become a little bit lazy, because if it's a little off, I say, all right, don't worry, we'll manage it and get it aligned with the 6 axis ultimately. But otherwise, we fix ring number 1, ring number 2, and put something under the non-union so that there is no posterior sag or recurvatum. Once you've done this, then put in fixation on the second ring and on the third ring. That should more or less ensure. You may still get a little bit, but it's not much. There's one question for Vasu from Dr. Koshi Idukula. Didn't understand the heel raise principle. Will heel raise increase equinus? How it improves dorsiflexion? Vasu?
No, the heel raise is not to improve any ankle movements. It is to prevent refracture at the non-union side.
Yeah.
The patient is already having an equinus. So if he tries to walk on that, the heel will always try to touch the floor by creating a reverse deformity at the non-union side.
Correct.
So his body weight will break the union. So I want the full mechanical axis to go through the middle of the shaft of the tibia. So that is the job done by the heel raise. It has nothing to do with the ankle movements.
This is somewhat similar to FRO that we use in polio.
Yeah.
Floor reaction orthosis. When there is equinus in polio and patient steps on the foot, the tibia gets a backward movement as the heel tries to touch down. So when you give a equinus heel, that is stopped, and whatever load is there on the tibia is then straight. So there's no abnormal force acting on the tibia. I hope that is understandable. If not, just put a question again and we will clarify it further. Right. So thank you, Vikram.
Time for just one more question regarding the stimulant. Do you mix it with any particular antibiotic, or do you have a choice of what to mix it with in your practice? What do you do?
Oftentimes we will try and get if it's a deep infection, we'll try and get a culture by aspirating from the non-union site.
Okay.
About 7-10 days before the surgery. That's one thing that we can do. Or if we don't have a culture, or if the culture has grown nothing, then we use this thing, Tobra and vancomycin.
Fine, Tobra and Vanc. Okay.
That is a generic thing that we use.
I'm not a good fan of a stimulant.
Yes.
Instead, I just put a drain in the lowermost interlocking screw and keep it there for some more time.
Drain of the interlocking. Okay.
Nail, infected nail, there will be distal locking screw.
Yeah.
Just keep a small drain there and keep it there sucking for about 6 days or so.
I don't know, Vasu. I used to be a big
I know
believer in the power of
that space obliteration.
radical debridement.
Yeah.
But I have seen cases which have humbled me a little bit, in the sense of, the bugs are really bad and they don't settle down. And so now, as a part of our routine, especially because it's easily available to me, we interact with the infectious disease consultant even for the antibiotics, etc., that are required. I have a sense, though I can't sort of really prove it, that nowadays we tend to have more and more of these bugs which are resistant to everything, which was not the case maybe 10 years ago. So there is to me at least a role for this, as well as infectious disease people, so that there is teamwork. The synergy between antibiotics or the mechanism of action of the antibiotics, etc., is something that I know zero about today. There's so many things available. So I find it better to sort of leave it to them, and they tell me in a much better way as to what we can use. So yes, when it's not available, then you have to do the best that you can.
Similarly, is available. One is it's costly. Number two, 2-3 cases it has produced a serious discharge.
That now we know it is there, so we kind of, you're not worried about it.
I actually shove it all the way through the canal in these cases.
Yeah, like we did.
Yeah.
This particular one, we used it to fill in that dead space.
Yeah, I think that's become my standard policy now for the past many years. But like you know, I asked the question specifically regarding the antibiotic because sometimes these ID people will tell you to mix it with something else and clindamycin, etc. But I use it all the time for these diffuse osteomyelitis.
Right.
Anyway.
Okay, so thank you, Vikram. Now the next case is intra-articular deformity. Actually, it's a tibia with a valgus deformity. Arun is at a baby hospital. Arun, is he there or not? Only his picture is there.
Yes, sir.
Okay, all yours. Neeraj, just a request to you, if there's any questions on the Ortho TV site also, you can please add them or let us know.
Yes, sir. So, good morning, everyone. So today it's a post-traumatic deformity of knee. It's a short case presentation. So he's a 45-year-old male who presented to me with pain and deformity in the left lower limb. He was a soldier, and 5 years back, while in service, he fell from a rope during a routine practice session, and he injured his left knee and ankle. He sustained a fracture in his proximal tibia and talus and was operated in a military hospital. He continued in service for another 4 years. And after his retirement, while at home, he had a slip and fall and injured his left femur. He was treated in a nearby hospital. This was his gait at presentation. On clinical evaluation, he had scars, genu valgum, a valgus laxity on stress, and lateral joint line tenderness. His range of motion in the knee was from 0 to 100 degrees, maybe 110 degrees. And the ankle dorsiflexion was restricted by 20 degrees when compared with other side. X-ray evaluation, it revealed united fractures of femur and tibia with plates in situ. X-ray of the knee revealed, it showed a reduction in the lateral joint space and degenerative changes in the lateral compartment. Full-length X-rays were taken to assess the deformity and revealed genu valgum. United fracture of the talus is also seen. Malalignment test revealed abnormal MPTA to be the cause for genu valgum. There was also a femoral shortening of 1 centimeter. I thought of evaluating him further for assessment of the articular cartilage and step deformity in the lateral condyle. MRI was planned. The implants were removed to reduce the artifacts due to the implant. And this is the MRI. It revealed a depressed anterolateral surface of the lateral condyle of the tibia and relatively normal posterior side. There was severe cartilage loss in the lateral femoral and tibial condyle. Malalignment test was repeated on fresh X-rays, which revealed abnormal MPTA as before, with slight difference in the ankle. The proximal smooth line on the lateral condyle of tibia was taken for reference for the joint line. The step deformity was measured around 5 mm on the X-rays, whereas the MRI was showing around 10 mm of depression. So to summarize, He had a valgus of 7 degrees in the tibia, an anterolateral depression of around 10 mm in the tibial plateau, and a femoral shortening of 1 centimeter with cartilage defects. So my plan was to correct the articular deformity with an intra-articular osteotomy, elevation, and bone grafting. Extra-articular correction with Elizero fixator. I chose the fixator as I was planning for a lengthening hinge to compensate the femoral shortening and for a better accuracy in correction of the mechanical axis. So that's a Cora. Orange line marks the osteotomy. And that's the projected correction. So these are the intraoperative pictures showing the intra-articular osteotomy of the anterolateral defect, elevation and bone grafting. The elevated portion was fixed using a 6.5 mm cannulated cancellous screw. This was followed by an Elizero fixator application. A 3-ring construct was used. These are the post-op X-rays. Distraction started at 7 days post-operatively. The rate of correction was 1 mm per day, and complete correction was achieved in another 2 weeks. These are the clinical pictures taken 3 months post-operatively. He was very comfortable on the fixator. This is gait on the fixator. X-rays taken 4 months postoperatively, showing progression of consolidation. Fixator was removed at 5 months after doing a stress test. The AP and lateral X-rays with the fixator on shows that the proximal and middle rings are completely free of any connections. This is a full-length X-ray after Elizero fixator removal, showing complete correction of the deformity. And that's a closer view of the knee. These are the these are the clinical pictures taken 2 weeks after fixator removal. Knee flexion seems to be limited. To summarize, the total duration of treatment was 9 months, of which he was on fixator for 5 months. Complete correction of the tibial deformity was achieved and mechanical access was brought back to midline. He needs to be assessed every 6 months for monitoring the degenerative changes in the lateral compartment. These are the clinical pictures taken 15 months after fixator removal. And this is how he walks now. This is a comparative video showing his pre-operative and final gait. He's not having any pain and his gait is nearly normal. So the take-home message, the proper pre-operative assessment that leads to a better understanding of the deformity and proper planning and execution of the case. Staged procedures have better soft tissue response and good compliance, and it causes less confusion to the patient. Thank you.
Okay, so just go back to your MRI picture. Why did you do a CT instead of an MRI? If you want to look at the bone, I would expect a CT to give you sort of more information, no?
Yes.
Okay, that one, yeah. So now my question is, what have you done? Did you cut this part? That is did you cut, one sec. I just marked it. Did you cut this part and elevate this whole thing, or did you lift up something over here?
Sir, I'll just show my just a second. These are the intraoperative pictures. You can see that the osteotomy it's a bit oblique here. I think you can appreciate my marker, my pointer. It's an oblique osteotomy. It runs from the on the sagittal view, it runs from the anterior to probably just.
Right. So you have lifted that whole fragment up.
Yes, sir. And filled with bone graft. These are the iliac crest bone graft.
That's true. That's true. But you have essentially you have lifted up that entire thing. You have not tried to lift up only a punched out portion.
No, the entire thing.
Yeah. So the question then is, what is sort of the most important part over here? Is it that lifting up, or is it the laser out? That's question number one. And question number two is, if the idea is to unload, then why didn't you go into varus?
So the
instead of going neutral?
So final correction, I'll just go show you the malalignment test. It is not going in for varus, sir.
That's what I'm saying. Why didn't you go into varus? If you want to unload that side,
yes, sir,
then going into varus may not be a bad idea.
Yes, sir.
It's a trick question.
Sir,
when you are neutral, you are still taking 70% of the load on the medial side.
Medial side.
Yeah. So what I am wondering is, probably just this elevation would have been okay, because if you look at this what we call the TCVO,
yes, sir,
transcondylar valgus osteotomy, which they do in osteoarthritis. There the theory is that if you reduce the instability, the issue of osteoarthritis, the pain of osteoarthritis and the progression of osteoarthritis goes away when you have a pagoda tibia. So in this case, and we've done a few cases where we have raised the medial hemiplateau, it has not gone into the valgus that we talk of in terms of 3 to 6 degrees, but the patient is comfortable. So my question here is that once you have elevated this lateral condyle and removed that instability, valgus instability, which was there because of the depressed condyle, probably that the additional varus correction may not be required. I can't say for sure, but I will welcome what Badri has to say about it, what Vasu has to say, and if anyone else has an opinion.
Sir, here we have got two deformities basically. One is that extra-articular deformity of extra-articular valgus deformity, and this intra-articular step. So I decided to correct the valgus definitely for correction of the sir.
No, but
only intra-articular valgus, no?
Where is the why did he have valgus on the left side and not on the right side? This extra-articular depends on how you draw the line. You draw the line a little like this. Yeah, show that picture.
Yes, no.
So this was a partial articular fracture, wasn't it? This must
Yes.
have been a split depression fracture. It was not a bicondylar fracture of the proximal tibia.
No.
I'll just show you the pre-op this thing also.
Yes.
It's a long. Yeah, this was the pre-op.
No, question is, what was the original fracture? Because if it was a bicondylar, then there is a possibility that the shaft also drifted into valgus. But if it was a pure lateral depression, then the likelihood of a metaphyseal deformity is less.
Zero.
Yes, sir.
Now take
So
the
what-
other X-ray. Show the other X-ray, knee X-ray.
Yes, sir.
Yeah, that knee X-ray.
Yes, sir.
Yes. Yeah, that is the middle joint is perfect.
Yes, sir. The middle joint is perfect.
Yeah, it is this one. And posterior part is also good.
Yes, sir.
This is a posterior line.
Yes, sir.
The anterior line is here. So what it needs is actually you have to do an osteotomy like this and tilt the anterior part up.
Yes, sir.
And at the same time, you have to look at the meniscus.
No, which he has done. That's what is my question. That if you had done just that much, would the result have been equally good? Is my question.
When I planned on this X-ray, sir.
Your virus stress view X-ray?
No, sir, I don't know.
You must.
Oh, now see, what have you planned on? Where is your angle? Your proximal joint line. You are taking into account the depressed lateral condyle.
No, sir. I haven't. The depressed. So here I've written that the depressed. I've taken just posterior to the depressed. I've considered two options here, sir. The femur I've taken into consideration, and also I've reduced the JLCA.
How much was the JLCA?
5 degrees.
Okay.
5 degrees. So since the femur is normal here, I extended the femoral line and also subtracted the JLCA to get the proximal line. So that was coming almost normal to almost okay with this planning, sir. There's, in fact, we have a double shadow here. In fact, triple shadow. The posterior line is also seen, and here out of the double shadow, I've taken the proximal line, and I've opted for Ilizaro only because there is an inaccuracy in this planning. Otherwise, I would have gone for a plate correction also.
So that is what I was thinking, that in this particular case, that is what I would have looked at first, and then kept the Ilizarov as a second option. Badri, what would you have done for this?
Yeah. You must have taken a pure valgus and virus stress view.
Okay, sir.
And once you do a full virus stress view,
then use the femoral joint line as the tibial joint line.
Yes.
I think this is a pure articular deformity.
How much angle you have done in the tibia?
Sir?
How much angle, virus angle you have done in the tibia?
Sir, correction, sir?
7 degrees.
7 to 8 degrees, sir.
Yeah. How much was the
out of which 5 was the JLCA?
Yes, sir.
So really speaking, only about 3 degrees in that sense.
Go
to your final correction pictures, show. You've done angles at that time also, no? Yeah.
I brought it back to 87 from 94, sir.
Here, what you have to do is you draw the proximal axis like this.
Yes, sir.
And the distal axis and find out how much is the angle. I think that is same as your preoperative.
Are you getting it?
Sir,
now you got a normal proximal tibia.
Yes, sir.
So do a deformity planning on this case, and you will find there is no deformity. That is the point we are trying to make. Badri, your opinion. You were saying.
I think this is an articular deformity. You got a great result, but my feeling is that this was a pure articular deformity, not combined metaphyseal and articular deformity. I'm not decrying the result. Okay, you got a fantastic result, but something tells me that this was a typical split depression. It was not elevated fully. We see a lot of these, particularly in women where the bone quality is good and it subsides, and they all come with this valgus due to the partial articular split.
Yeah, that is the point. When you have an intra-articular deformity, can you justify it by an extra-articular correction?
No, he has recognized the intra-articular and he has corrected the intra-articular also.
Yeah, very nice.
But I thought there is
additional extra-articular is required or not. Our three of us, our thought process at the moment is that probably not. So I would say that maybe next time when there is things like this, two things is one, as Vasu said, do a varus chest X-ray and use the joint line of the femur as the joint line of your tibia. That's number one. And number two is discuss with the patient and leave it as a staged option. That see, it seems to be 80% from the articular surface. I've done this in patients with varus, and a pagoda tibia, I say, okay, let's correct your varus with the Elizarov. And then if you are still having trouble, if there is still a little bit of instability, we will do the intra-articular portion. I've done that reverse because they were, developmental abnormalities. But for a fracture, especially now with the amount of, we've done a fair number of these TCBO cases. So we don't correct, it doesn't correct their valgus huge, completely to 183, 186, but it improves it markedly. Okay. And then those patients are symptom free. Once their stability is restored, the intra-articular stability, okay, then they do well. Okay. So that is something to take away from this one, because your MRI was quite significant in the sense it showed that lateral condyle, the whole thing has shifted down.
And I prefer a CT scan over MRI.
Yeah.
Sir, we usually do a CT correlation study also, sir. I don't have that pictures right now. MRI was, I asked for an MRI with CT correlation to see.
You must have asked for MRI.
No, so that is still an acceptable excuse, because someone else would say patient could not afford CT. Patient could afford my surgery charges, but couldn't afford.
Mangal, do you use this 3D modeling? Because I know you were thinking about it.
We are using it right now. We are working with a group of ex-IIT people.
Yeah.
So we are still in that prototype stage. Once we have it ready, then you, Vasu, other people also, we will be kind of trying to involve to find out the bugs in it or the issues in it. So right now, the issue is we are converting 2D into 3D.
Okay.
By means of an algorithm. We do X-rays with the AP lateral. Maybe one of the next meetings, I'll show you what, I'll do a talk on what we have been doing. So probably another maybe 3 months or so before we get that ironed out, and then get other people also involved in that.
Sir, I have a question on this, sir.
Yes.
In this X-ray, I've already done the elevation and fixation with the 6.5 mm screws, sir.
Yes.
If it was a pure articular depression, the mechanical axis would have been corrected right now, sir. I mean, the first X-ray itself.
Yes.
So
it's also possible that you have done an incomplete correction of the intra-articular portion.
Okay.
These are really challenging, intra-articular, because
so that's what I said. Nobody has a sure answer for this. Nobody can say that, oh, I've done 10 cases of this and therefore you are wrong. You may be right. Not that, but our thought process currently is along these lines. So the next time someone gets it, you can try it and see, and then you'll be able to educate us. So there's no right or wrong. It's just how currently we are thinking.
I don't know. You have put a 6.5 mm screw, no?
Yes, sir.
What is the size of that fragment? So your osteotomy found to be very, very high. So you need little more bigger fragment to elevate.
Sir, it's an oblique. You can see this is the.
Yeah, this is actually not enough. I would like to do little more bigger like this.
Okay, sir.
The fragment, probably we would go something more like this, so that you've got a good chunk, because this portion is all compressed down. So this area of bone is the really good bone.
Okay, so in fact, the marker where you're kept, you can see the gap also.
Yeah.
That
fine. So good because that makes up it brings up all these questions and differing thought processes. That's what is important in a case discussion. Okay. So great. Thank you, Arun. And now I think the last one we get Divya.
A question, Arun, had you put on a tricortical graft, or that was just cancellous graft?
Tricortical graft.
Okay.
You can stop sharing, Arun, and Divya can share.
Fine, sir.
No, unshare it. Yeah.
Good morning, everyone. we'll discuss now about vascular fibula. Is a fracture a good thing or in it, or something? How would you manage? So vascular fibula, we know that a good microsurgical team, microsurgical skills are important, and it helps us to fill the large bone gaps. It can also add on soft tissue cover if required. Goes on for early unions, and in the long term, the fibula hypertrophies and becomes as good as the normal tibia width. The disadvantages are that we need protected weight bearing for a long time. They are prone for stress fractures, and it is a big surgery, big task to ask for. So let's see how the usual story goes with the vascular fibula, and learn some tips on how we can sort of manage it well. This is a 21-year-old male, had a closed fracture in the tibia. Usual story, nailing was done, then got infected, had multiple debridements done, and then finally implant removal was done and X-fix was put on. And he presented around 1.5 years later with sequestrum, bone defect, discharging sinuses, and equinus deformity. The orange arrows show the bone gap which would be created at the end of the debridement. So the options here are pretty open. One can do bone transport as well after the debridement. But this was a patient from Nigeria, so he would have to return back and will not be able to follow up as easily as required, especially at the time of docking. It will be difficult to monitor his lengthening, so we chose to go ahead with the vascular fibula. That will be a one-shot surgery, will help us take care of the infections, soft tissues, as well as the gap with that. Does require a little longer stay in the hospital, I would say, to manage the wound, but overall, a single shot surgery can be planned. So the anterior tibial vessels are explored. The fibula graft is harvested. We harvested around 23 centimeters of fibula here, and then proceed with the debridement. Take away all the dead bone, whatever is there. The medial portion here was all right. We tend to fix our fibula intramedullary, not use any internal fixation to hold the fibula. So we'll create a channel into the canal, central reaming, to get good alignment. Put on a frame, use rods and wires to guide the alignment. That is what is more important here, to get good alignment. And then put on a frame like this, which is more like a neutralizing frame, has a proximal fixation and distal fixation. The middle ring here is a dummy ring. And once the fixation's completed, alignment is maintained, then we remove the lateral half of the dummy ring to allow access to the plastic surgeon to continue with the microsurgical anastomosis. Then we disconnect the dummy ring, shove in the fibula intramedullary. At this point, kind of the orthopedic work is done with. Our alignment is restored. The fibula is being held. Generally, it is a scratch fit. We will not over ream it, but at times you may need to narrow the ends to push it in. And once that is done, they finish off with the anastomosis and the post-op X-rays do show a good alignment, and the gap is all the way filled up with the fibula. Stimulant beads were put in because this was an infected non-union. And he goes on to good union. He goes back to Nigeria once the wound was healed. Antibiotics, initially IV antibiotics for 3 weeks was given till the CRP was normal, then converted to oral antibiotics. We allow them a partial weight bearing to begin with, around 5-10 kgs. As things improve, they continue on with up to 50% weight bearing with the walker. And the goal there is generally they are healed around 3.5 months, but we will continue to use with the fixator to keep them getting much better at their rehab and walking, etc. Then shift them on from a walker to a stick and call them over for a stress test. Once all is good, at 6 months, healing is done, gait is good, fixator is removed, then they go into a cast and allow full weight bearing with the cast. And then they continue on with the above knee brace initially with the hinges locked. And as the fibula is hypertrophy, we get them onto a hinge open for walking as well. So this is at 1.5 years. We can see well that the fibula is already hypertrophy. All that intramedullary fixation and good alignment has given us a good result, and there have been no stress fractures for this patient. But this is not the usual story always. So here the learning points, what we want to make for a vascular fibula are that this is a single surgery. Intramedullary fixation helps in the additional stability. It avoids any implants inside, especially in infected non-union. That is something what we would anyone would consider. And there is early and predictable union. The fixator acts just more like a neutralizing mode, and maintaining alignment prevents any stress fractures in the fibula. The protected weight bearing will continue till the fibula is hypertrophied, and then they continue with the brace, and then the brace can be removed. But all is not well always. So what happens if there's a stress fracture? So in this first case, this 17-year-old boy fell from a train, had sustained a grade 3B compound fracture with bone loss, debridements, external fixator, skin graft, everything done. And then once everything settled, they went ahead with vascular fibula. And we inherited him at this stage. He's 2 years post-injury. Fibula has already been done. A biplanar external fixator was there. He's not been walking for two years. And there is shortening as well. The fibula is placed with varus proximally and valgus and recurvatum distally. So we decided, because the ends have healed and he's not really been walking, we wanted to challenge this fibular union and see what happens. So the fixator was removed. We gave him a brace for protection, added race for the shortening, and started weight bearing. Gradually, he went on to walk unaided with the brace. And at 3 months, this is the follow-up, further consolidation at the healing. And he's been walking well without much trouble. And then he presents another month later with no history of trauma, no sort of missteps or any injuries to preempt this. And on that follow-up, the X-rays showing undisplaced fracture of the fibula. So since everything is in position, we allowed him to continue walking with brace. Within two weeks, they start showing a good amount of callus forming already. The pain has decreased, and then he continues to walk on and heal well at the end. No further angulation changes, continues to walk well. At 1 year, all that callus has allowed further hypertrophy of the fibula. So this second case, 23-year-old boy had again similar story, compound fractures, other injuries as well, all managed, and then presence with an infected non-union to be managed. So already a big sequestrum was there in the tibia. The skin looks all right, just discharging sinuses from the sequestrum, but we were not sure how much sort of is the infection, so went ahead in a staged manner, debridement, stimulant, and then put on a fixator to maintain the alignment. And at 6 weeks, once everything was settled, the bone gap was around 20. So transport was an option, but again, smaller sort of size fragments remain. Issue would be where to do the corticotomy for the transport. Long fixator time, already patient troubled, so went ahead with vascular fibula. And the fibula again shoved in intramedullary. How much fixation intramedullary can one get also gets sort of dictated by what kind of fixation you are using. If this was an Elizero fixator, then we could have gone ahead with a longer fibula on both the sides. Also depends on the plastic surgery team, how much are they comfortable with. One can play on table with the length a little bit, can shorten to dock it, and later on lengthening can be done or managed with a shoe raise. So we went on to have good healing, and ultimately the fixator is removed, went on into protected weight bearing with the walker. And at the time of that, because we were not sure of the proximal healing here, and this cleft is there, so we wanted to protect it with an internal splint. So a tense nail was done at the time of fixator removal. We put in the tens, negotiated through the fibula, and allow them walking with a cast, moving on to a brace. So because he also had that knee dislocation and a stiff knee FFT at the knee joint, there was a push knee kind of sort of padding given there, but that didn't really help to straighten out the FFT. We allowed him good, a free ankle range with the brace, and managed the shortening with the shoe raise. 3.5 years, perfectly well, everything going on good. Fibula is hypertrophied, almost sort of 1.5 times to its original size. And he continues to walk without any trouble. At this point, he decided that, okay, the brace probably can be left off, but he had a fall. And then he was not able to walk because of the pain. X-rays were just showing a faint sort of fracture line at the proximal tibia marked by those orange arrows, proximal end of that fibula. And because the tense nail was there, probably it didn't displace. So we continued, we gave him a cast, walking for a few weeks, and with that already the callus had started showing up. He was able to walk without any pain, and we moved on to go back to the brace. And at 2 months, it's already showing good healing and callus. 6 years on, perfectly well hypertrophied, all that cleft which was earlier seen because of the fracture, hematoma, that is also now filled up well. continues to walk without the brace, manages the shortening with the issue raise. 8 years on, it remains well healed without any other issues. The fibula is almost become the size of the original tibia. This third case was a bit of a challenge. Our case done elsewhere, not our regular team for managing the plastic surgery work. We were called in to do the orthopedic part. Slightly older patient, 57-year-old male, grade 3 compound comminuted fracture of the tibia. More proximal, very small chunk of proximal tibia was left. There was a 20-centimeter gap and soft tissue defect as well. So filled in with vascular fibula and neutralizing Elizarov fixator. So I will start the story at 11 months post fibula. His distal union had gone on well. This fixation was slightly, there was slight valgus at the distal fixation. This posterior shell of bone is the original tibia which was left. And we had a very small amount of hold in the proximal tibia. So we did put it in intramedullary, again going right up to those proximal wires. And he did take some time to have achieve union in the proximal interface. But at 11 months, he was walking well, and it does show a good amount of union. Our plan was we will see, dynamize and see it, how well is he able to walk, and then plan for a removal at 4 weeks. And after the dynamization, he comes up and shows a stress fracture in that proximal third portion of the fibula. It's already showing signs of healing, so we don't know when he broke in the intervening period. He had no pain at all. And then we continued with the fixator at 1 month post that X-ray. It's already showing good signs of healing and callus formation. Another month went on. The proximal union has improved. And then 3 months post fracture, we now plan to do a stress test again. So rods are loosened. He's walking unaided. There's no equinus. There's no FFD at the knee, good range, walking well, and we planned for the fixator removal and checked under the C-arm, which is generally what we will do. And the orange arrow pointing on the right side is showing non-union at that fibular fracture. So we did a CT scan at this point, confirmed that because all wires, etc., are removed. So the CT scan was done more for confirmation at what is happening at the proximal and distal interface as well. CT showed good healing there, only the hypertrophic non-union at the fibula remained. So we took him up again and inserted the TENS through the fibula and applied again a neutralizing Elizarov frame. Putting in the TENS was a task through the hypertrophic non-union because this area was filled up with bone. So we had to open it percutaneously here and enter in with a drill bit and make a channel. Then we could put the nail through. So story continues at 2 months post fixation. Then healing has further improved, not complete yet, but he's been walking much better than earlier, much more comfortable. No issues with the pin sites. And this time we did a CT scan before planning for any union removal. The CT orange arrows are showing good continuous healing. All the interfaces already proximally distally were healed, so that was not an issue. And we took out the fixator. On removal of fixator, that's where the green arrow is showing another stress fracture. Now this stress fracture was obliterated by the ring, that dummy ring which was there, and not seen on the CT scan at that point. But it was not displaced, already showing healing, and because the proximal hand is being protected by the tense nail, so we put on a fixator. There is this distal valgus, which is probably the cause for these repeated stress fractures, but all the stress fractures are a good thing because they have increased the cross-sectional area and hypertrophy of the fibula in no time. At 2.5 year follow-up, everything healed up well. He's been walking, asked now to walk without a brace in another couple of weeks. He should be weaning it off. So stress fractures in vascular fibula, undisplaced, they are a good thing because it helps to hypertrophy the fibula really well. Malalignment in placing the fibula is makes it prone for fractures. Conservative treatment works well for these stress fractures because largely they are stress fractures and undisplaced, so may not need internal fixation always. Internal splint and external splint for protected weight bearing is recommended to prevent any fractures, or if they do fracture, then prevent any displacements. And in general, good hypertrophy of the fibula is noted around 2 and 2 on an average at 2.5 years. That is till when one needs to continue with protected weight bearing. Thank you all for the patience.
Thank you, Divya. So that was, I think, an excellent exposition on the use of a vascularized fibula. And that last case especially showed what a powerful tool the vascularized fibula can be. So we are now, whenever we are involved in doing a vascularized fibula, it's de rigueur now for us to use the fibula as an intramedullary nail. Our plastic surgeons, we have two teams that we are sort of associated with. They are very comfortable with getting out these long lengths of fibula, and we can put them. It's a little fidgety at times, but it's absolutely worth the trouble. Once you get it intramedullary, then there's no, I've seen so many vascular fibulas fixed with a screw or fixed with a couple of screws, and those, they always fail in those areas. What this guy, the last case, showed is a very old principle of orthopedics, which was, I think, from the beginning of orthopedics, which was called a defunctioning osteotomy. Was it McMurray who talked about it, where they would do the osteotomy and displace it, and then the fracture neck femur, which was above it, would heal because it was spared of all the forces.
That is Palterineri.
Who?
Palterineri.
Okay. So I stand corrected on that. But essentially, that you could see that in this guy, the moment he had that proximal fibular fracture, his healing on the proximal end of the fibula, it improved very, very clearly, and because all the forces were now being applied to that non-union area, which despite all that callus had not healed. And then the moment we added that intramedullary wire and reduced that and allowed him again weight bearing, he healed on that. So the vascularity was important for that. And these, due to the creeping substitution, these fibulae are known to undergo stress fractures. So I think when you have it well aligned, then the downside of that stress fracture is reduced. We've done now, I think, 3 cases, if I'm not mistaken, where we've put in a tens nail through the marrow of through the canal of the fibula as an internal splint, and it's a fantastic thing to take the weight off your shoulders. You stop worrying about whether it's going to displace and can I fix this with an Elizarov. Then you just have to fix the Elizarov proximal and distal, and this intramedullary tens nail takes care of the rest of it.
Which size nail you use? What is the size of the nail?
Whatever is the biggest that can go. I think what we've used here is about 3 mm.
Oh, 3 mm.
It goes in without too much of a struggle.
So you're doing it acutely at the time of the fixation, right? The tens nail as well.
No. The tens nail is only when we've had fractures. The first case which Divya showed, those when everything is under our control, then we can get the proximal and the distal fragment perfectly aligned, and we can get the fibula subjected only to compression. Yes.
No shear at all.
We don't need that. There's no shear or no bending force.
Yeah.
The boy that came later, he fell and he had an injury.
Okay.
So for him, we wanted to sort of protect it. So we put that fibula into him. Though he was well aligned, we put that. This guy, I think, had the last case that he showed, he probably had because we were working in a theater which we were not normally used to. He had some earlier issues because of which he was malunited, and we couldn't get it perfectly straight. But as long as we got it intramedullary and we had it stabilized, we thought that he will do well. So he's taught us probably a lesson in the sense that the next time we have a case like that, we will still struggle a little more and try to get it absolutely straight, which we are doing in our own sort of environment. We can do that without trouble.
Yeah, if you try to do it on day 1, probably that will spoil the intramedullary blood supply.
Yeah.
Yeah.
So it's not really needed.
That's why I asked, whether he was doing it on day 1, because the amount of drilling and all that you need to get it through, the fibula will start spinning, won't it? I think you'll be in trouble.
So we don't do that.
Yeah.
Through the fibula, actually, what we've done is we've just tapped it through. So whatever is the largest, it will accept. We don't drill through the fibula. Except in this case, the proximal end, it was blocked with all the callus. So we opened it a little distal, hyperangulated it, and created a channel into that proximal segment, and then reduced it and banged the nail through. That's all.
What I don't have a plastic surgeon.
We tried initially closed, but the nail would come out.
So I don't have a plastic surgeon.
Sorry?
What I do is I take the same side fibula if available and slowly transport to the gap of the tibia, and second stage I will just put it into the middle.
Yes.
So it's a 2-stage procedure.
Yeah. Ipsilateral vascularized fibula.
Yeah.
With
plastic surgeon's help.
Doesn't need, there's a question from Dr. Satish Nesari. Any experience with non-vascular fibula? I have experience with 2 non-vascular fibulas. They were meant to be vascularized fibulas, but by the time the plastic surgeon finished, they found that there was not good blood supply through the anastomosis. They revised it once on table, still it didn't improve. So then what we did was we took off all the soft tissue and use that just as a splint, internal splint, and added the Ilizarov externally. That Ilizarov was a more sort of stable fixator, and they were not that large gaps. They were kind of more of overlap, but they had the fibula partly because of the this thing. The bone gaps were not good and the skin was not good and stuff like that. So in those cases, they have healed well. One of those patients healed without any complication. The second patient also had a stress fracture, and he had he was continued in the brace, and his tibia showed adequate callus response. So he also kind of healed off. Dr. Koshi asks, what is your experience of vascular fibula in humeral non-union, whether you can use a whole or a split fibula? I think you can't use in case of vascular, you can't use a split because then the blood supply is gone. But in humerus, I have done multiple times avascular fibular strut more as an intramedullary sort of augmentation of external fixation, and they have worked well. I'm not sure whether it's the fibula which is working or whether it's the external fixation. I think primarily the external fixation, but the fibula definitely serves to improve that stability because it takes away the bending forces, and then we just compress over that. Maybe we'll some of the later talks we will share those cases.
In the unit, we used to do the vascularized fibula for the large humeral gaps, initially fixing it, as Mangal said, with 2 screws, and they all used to fail. So we use a vascularized fibula, but with very long plates as well as short plates around the anastomosis side.
Very long plates,
as well as 2 small plates around where you fix it, into the ends. We don't use the intramedullary into the humerus. Mangal, I don't know whether you use it in the humerus as well. Do you put it intramedullary?
Yes.
Okay.
But those are avascular fibulae, and they're used more for a non-union.
Okay.
You put the graft as an intramedullary nail.
Exactly.
Okay. So I'm talking vascular, squaring off the ends, absolute stability with 2 small plates, and then a long spanning plate.
But if it was a humerus, I would use exactly the same argument for a vascular humerus with a gap. I would use an intramedullary and use some sort of a dynamic fixator on the outside. I'm so impressed with the ability of the fixator to further compress as required, and which is why I'm very wary of using any fixed device which then takes away that option. Vasu?
Yeah.
Humerus?
Humerus I have not done. I don't do much of fibula. The plasticity is not there. Free fibula we have done enough.
No, so that's what pre-fibula. You especially when it's osteoporotic and all that. I think the pre-fibula does the job pretty well. Great. So I think today was again a lovely bunch of cases, each of them, bringing up a lot of thought process. Everyone can just put on their cameras so we can get a screenshot. Yogesh and Neeraj is there or away? Arun? Yeah, okay. Okay, thank you. So with that, I think I will end the streaming.
Yeah, Mangal, some people are asking for YouTube link.
YouTube link is, I will, where are they asking? I'll send it to you. You can
Share
pass
it.
it on. This is recorded, and the YouTube link will be available. I'm just I'm trying to get my streaming screen up so that I can stop the stream. You guys can just stay on. Neeraj? Vasu, even I had sent you a link,
Yeah.
which had the link called bit.ly/CLLR-YTL. Even if you go to that link now,
yeah,
they should be able to see it even after the live stream has ended. And later on, they will be able to see it on another link, which I will send you. Neeraj, is